Well, good evening, everyone. It is 7 o'clock, and just a quick sound check. Someone could just throw in the chat if you can hear me. Sounds good. Lovely. Thank you very much. Perfect. Well, good evening, everyone. Welcome along to another Monday evening webinar. So it's next in the series of the interactive sessions that we're doing at the moment. Around pathophysiology. We started last week with some respiratory pathophysiology. Tonight we're going to talk about cardiovascular side of things. It's part of a greater series which is looking to help those of you going through the FREC pathway predominantly. So those of you going from FREC 3 to 4 specifically, but of course 4 onwards as well. We're looking at some of the subjects that you'll need to be able to get your head around before going for FREC 5, for example. So hopefully this is proving useful to those of you that have been along already. Those of you that are new to this, so welcome. SDC Training Solutions is a first aid and pre-hospital care training provider based in the southeast. We train predominantly from our Aylesbury base at the moment. We do our kind of bulk of our work is FREC 3 and FREC 4 courses, and looking to start FREC 5 fairly shortly. So if this is something that you're looking to get into, then please do get in touch. We do have courses coming up, which I'll show you about in just a second. Those of you that haven't met me before, welcome. I'm Innes. I'm a paramedic practitioner by trade, work for a couple of ambulance services, still do so on bank contracts, and work full-time in a GP surgery. And cardiology and cardiovascular system is my area of interest, actually. So tonight is my kind of bread and butter. So if you have any specific questions, then please do feel free to ask as we go through. Looks like there's a lot of familiar faces in the audience, so welcome along, and a couple of you out there doing our FREC 4 at the moment. So hopefully you're finding this stuff useful as you prepare for that. So here we are. As I said, we are a FREC training provider. We do have a couple of courses coming up. Just of note, the 2 FREC 3 courses are nearly sold out now. So if you are interested in doing a FREC 3 with us in the next few weeks, then do get in touch to secure a place. We have 2 options, one over 3 weekends, runs over 3 consecutive weekends, 5 days of contact. That starts on the 5th of June, and then we have a Monday to Friday course, which starts on the 12th of July. So get in touch if you'd like those. We have a FREC 4 course, just missed one, which is kind of running at the moment. So the next one starts on the 10th of July, again runs over 5 days. We deliver our courses, FREC 4 courses, over the 3 blocks that Qualsafe designed it to be delivered over, rather than the Monday to Friday. We find that doesn't work. So 3 blocks, and in between those teaching blocks, you complete your workbooks. Much more civilized way of doing things than cramming it all into 1 week. ILS, if you already have your FREC 4 and would like to do the annual ILS with us, our next one is on the 27th of June. And again, if you'd like to bolt on the SARM, if you haven't already, Safe Administration of Life-Saving Medication, that next one is on the 17th of July. That's just a 1 weekend, 2-day course. And of course, those of you coming to us through the webinars are entitled to 10% off, so please do use the discount code webinar10 when you check out, if you do so through our website. And we look forward to meeting some of you in the flesh in the future. So enough of the plug. What's the series covering so far? So far we've done CPD requirements and some anatomy and physiology. Those videos are available to watch on YouTube if you did miss those. And we're currently on the common pathophysiology section. So last week, we talked about respiratory. We're talking about cardiovascular tonight, and neuro next week. So this series is going to cover some maternity care. It's going to cover patient assessment, particularly paediatric assessment. We're going to talk about sepsis, oxygen and Entonox guidelines, some ECGs. So tonight we're going to talk about some cardiovascular stuff, but we're not going to talk about ECGs tonight. So that's going to come up later in the series. Of course, there is a whole webinar series which we filmed last year on ECGs on our YouTube channel if you wish to view that. And then we'll do a session on intermediate life support. And just for a little recap, obviously it doesn't replace your need to do an annual face-to-face, as we say. So tonight we're going to talk about angina. We're going to talk about acute coronary syndromes. If that's not completely new to you, we're going to talk about heart failure. And then there'll be a question and answer session. As I say, we're not going to discuss anything to do with ECGs, such as atrial fibrillation or actually what ST elevation is, etc. tonight, but we will cover that in a future webinar when we talk about ECGs. It's just much easier to talk about all of that in one go. So, but if you have any questions as we go through, as I say, put them in the chat and I'll do my best to answer them. So, but there will be a Q&A session at the end. Those of you that have been along before, you know we like these to be interactive. So Charlotte's in the chat tonight. So if you want to ask any questions, she'll more than happily help with the technical side of things. If there's anything I see as we go along, I'll try and answer as we go. On Mentimeter as well, we're going to use Mentimeter again tonight, so get your smartphones ready at menti.com and I'll give you a code to put in, which will allow you to answer the questions in real time. And then we have, you can contact us by tweet, by email, by WhatsApp, and of course that goes on after the webinar has finished as well. If there's any burning questions you can think of that you wish you'd ask, just drop us an email or a call or a text. Really recommended reading for those of you going through the FREC pathway, depending on what level you want to go into. The absolute bare minimums, I would say, are the Ambulance Care Essentials and Ambulance Care Practice volumes on the left and the right of your screen. Ambulance Care Essentials is the core text for FREC 3. Anyone that's done the FREC 3 should have been given a copy of this by their training provider. And Ambulance Care Practice is the core text for FREC 4. So anyone that's done their FREC 4 again should have a copy of that. We do advise Ross and Wilson for the Anatomy and Physiology textbook of choice. That seems to be pitched at about the right level, although it does go into a lot more detail than you need for some of the areas. Another book that I found particularly useful has been Pathophysiology, a practical approach. That's by Rachel Story. We have these books. All of these books are available to purchase on our website, but Ambulance Care Essentials and Ambulance Care Practice are included with our respective FREC 3 and FREC 4 packages. So if you're planning on doing it with us, don't bother buying those. But Pathophysiology and Ross and Wilson are definitely good additions to any library. So we're going to get interactive for the start. So let's go to menti.com. And then if you pop in the code 27208876, that's 27208876. And it's a free text answer, this one. So I'd like you to answer, what are the functions of the cardiovascular system? You can put up to 3 answers, you don't have to use all 3. So what are the functions of the cardiovascular system? Everyone have a go at answering that. Wait for the first brave person to put in there. There we go, look at that. Pump blood and exchange gas. Well done, whoever the first was. Good. Let's get a few of you. There we go. Lovely. Exchange gas, pump blood, remove waste. Good. Transporting. Good. Pumping blood. Oh, lovely. Yeah, sending nutrients around the body. Good. Because it's not all just about gas and pumping blood. Good. Transporting waste. Lovely. Good. So a little bit of overlap with the respiratory system we talked about last week, isn't there? And the gas exchange actually is a function of the alveoli of the lungs, but of course the respiratory and cardiovascular systems are very kind of intrinsically linked, in that one can't survive without the other. So if you the whole purpose of the gas exchange actually is a function of the respiratory system. But the cardiovascular system obviously supports that by circulating the blood that has been kind of oxygenated and carbon dioxide removed. But good, we are absolutely moving blood around, we're transporting glucose, we're transporting other nutrients, we're removing waste, not just carbon dioxide, other waste such as urea and lactate, etc. So very good, perfect. So we're on the right lines. If the cardiovascular system, if you're not familiar with its functions, then check out, I think it was episode 2 of this series so far. We talked about the cardiovascular system in some depth there. So well done. Let's head back to the PowerPoint then. So how does the cardiovascular system work? How does it pump its blood around? So have a little look at these diagrams, which hopefully won't be new to you. We're looking here at the diagram on the left, which is blood flow through the heart. So the heart itself is a pump. The vessels are obviously the kind of pipes that connect the heart to all the organs. And then we have to think about this as basically being like a central heating system in the body, don't we? Ultimately, or equivalent of. So your central heating system at home has a pump. It has a furnace, which in the body is obviously the lungs. So we pump blood to the lungs to be oxygenated, like your central heating system pumps blood over the gas fire or the oil fire to heat the water. And then the pipes are obviously the pipes that run to the radiators. The radiators in the body sense being the organs, which is where the heat's given off in the body's case, where the oxygen is given to the organs and the carbon dioxide and all the waste is collected. That then comes back to the heart and the cycle repeats. So just a quick bit of reminder, the right side of the heart deals with the deoxygenated blood, so blood arriving in the right atrium from the vena cava is deoxygenated, it's come from the body. That's pumped out by the right ventricle into the pulmonary artery where it's oxygenated by the lungs. That then returns to the heart, to the left atrium via the pulmonary vein. The left side of the heart dealing with oxygenated blood clearly as the left ventricle pumps, it goes through the aorta and off to every target organ within the body. So the heart itself is obviously included in that, and that's relevant because we are talking tonight about some cardiac diseases that actually affect the blood vessels that supply the heart itself. So one of the first two kind of bifurcations of the aorta as it leaves the left ventricle are the left and right coronary arteries. Now, a really interesting design feature here, as the aortic valve opens, it opens onto the openings for these arteries, because everybody thinks, well, actually, if that's the pressures in this initial kind of aortic arch are huge, and these are tiny little fragile blood vessels. You imagine you allow that full pressure of the left ventricle to pass down these blood vessels, they're just going to burst. So good design feature that the cusps of the aortic valve, as they open, they occlude partially the coronary artery, the entrances to the coronary arteries. So of course it's much more kind of gentle flow that enters these and almost kind of residual pressure once the valve shuts. So that's really interesting to know. And then of course the blood vessels themselves start nice and simple. So we have the left and the right. Predominantly the left feeds the left side of the heart and the right feeds the right and the back of the heart. We have the left coronary artery being the biggest and the most important, splits into two main arteries. There are several kind of bifurcations off that as well, but we talk mainly about the left coronary artery only splitting into two places, and that's into the left circumflex, which travels around the left side of the heart, and the left anterior descending, which, as the name suggests, travels down the anterior or the front wall of the heart down to the bottom. The right coronary artery we consider just to remain one main artery, although as you can see there are some bifurcations off that. So interestingly, we'll talk about this more in ECGs, but ECGs only have three kind of views of the heart, realistically, we talk about the anterior wall, we talk about the inferior view, and we talk about the lateral view, the lateral being the left side of the heart. It is possible to get a posterior view of the heart as well by moving some of the ECG leads onto the back. We'll talk about that in the ECG session, but by and large, we talk about three views. The right coronary artery supplying the inferior wall, because this is kind of the bottom if you looked up from the feet. I know it's at an angle. This is referred to as the apex, this pointy bit of the heart. The left coronary artery, where it travels downwards, is called the left anterior descending. That supplies the anterior wall of the heart, and the left circumflex supplies the left lateral wall of the heart. So the three views of the heart that we get from the ECG are broadly kind of split that way. So any inferior ECG changes are likely to be as a result of the right coronary artery, any anterior changes likely to be a result of the left anterior descending, and any lateral changes are likely to be as a result of problems with the left circumflex artery. But that's not always the case. We will talk about that more in the ECG session, but hopefully that just sets the scene for some of you there. So the important thing to understand about the heart is actually this thick middle layer. This is a kind of cross-section of the heart wall. We have a fibrous outer protective layer called the pericardium that's split into two layers, as with the pleura that we talked about last week or the week before. Around the lungs, we have the parietal and the visceral layers of the pericardium. The function of the pericardium is to protect the heart first and foremost and allow kind of lubricated relative movement. The myocardium is the muscle. Myocardium is quite literally heart muscle, and that is the doing bit of the heart. You can see from a lot of diagrams that the left ventricle is much more muscular, the thicker myocardium, and that's because the left side of the heart is doing a lot more work. It's pumping the blood a lot further. And then we have the endocardium, which is just the Teflon layer, obviously, to stop blood sticking. When blood sticks or blood comes to a standstill, it clots, and we don't want clots in the cardiovascular system as much as we can help it. So we will talk about a result of atrial fibrillation being strokes and things like that from clots forming. We will talk about that a little bit next week and again in the ECG session. So most important thing to remember is this myocardium cannot repair itself if it doesn't receive enough oxygen. Its first kind of response is to generate pain. So in a lot of the diseases we're going to talk about, all the diseases we're going to talk about tonight, there's going to be an element of chest pain. Okay, if the heart isn't working properly, it very much affects the lungs. So generally speaking, with these, we're also going to have breathlessness with just about every condition. So chest pain and breathlessness, we always think, could it be the heart? So the myocardium, when it doesn't get enough blood, will start to hurt. And if you keep it in that situation for long enough, or if you cut off its blood supply completely, it will die and it can't regrow. So once myocardium dies, it becomes thin, it becomes stretchy, it becomes baggy, and becomes useless, as we'll see in heart failure when we talk about it later. So pericardium, also known as the epicardium if you're American, myocardium in the middle, and endocardium, the Teflon layer of the inside the heart. But the myocardium is the worker bit of this. So let's go interactive again, and let's go to the next question. So it should be the same number, menti.com. You've got the code 27208876. I'll let you put that in the chat. So menti.com 27208876. What is heart disease is the question now. We've got up to 3 answers. You may not need all 3. Okay, well done. Here we are. Lovely. So heart disease. So high cholesterol, definitely linked to heart disease. Good. Dying heart muscle, yes, potentially. We are heading that way, aren't we? So that's really good. Uncontrolled hypertension can cause heart disease. Good. Lack of oxygen to the muscle, it's yes, in a way, it's lack of blood flow to the muscle, which is really good. Absolutely dying heart muscle as a result. Blockages, I like it. Not so much no oxygen, just a reduction in oxygen. Absolutely. Angina is the result of a lot of heart disease. There's brilliant occlusions. I like that. Death of muscle, narrowing of heart vessels. Brilliant. We're seeing some good answers there. Atrial fibrillation, not so much. Atrial fib isn't one of the heart diseases as such. So most people getting it there. Heart disease is a build-up of cholesterol deposits in the coronary vessels. Okay, in those vessels that we just talked about, the left and right coronary arteries. If you allow fat and deposits to build up in those arteries, you'll reduce the blood flow available to the heart. As that builds up, that's referred to as heart disease. So heart disease is build up of fatty deposits in the arteries. Angina is when that reaches kind of critical mass, if you like, and actually the heart becomes ischemic, i.e. not enough oxygen for what the heart wants to do. So brilliant. So uncontrolled hypertension and high cholesterol are definitely going to cause that, as does diabetes, poor life choices, poor diet, not enough exercise, that type of thing. But anything that raises your cholesterol is very much likely to put you at risk of heart disease. There's a couple of names given to that, and that's atherosclerosis and atheroma, arteriosclerosis, sorry. Atheroma and arteriosclerosis are the 2 names given to those fatty deposits. The latter, arteriosclerosis, being when that kind of atheroma, the fatty buildup, becomes hard and effectively permanently there, so it can no longer be reduced by any lifestyle changes. So that's good. Let's flick back to the slide then. So heart disease is this is build up of fatty deposits within the artery. Okay, so it starts to build up of atheroma, kind of fatty lipid deposits on the inside of our Teflon walls. and then it turns into arteriosclerosis, which is kind of hardening of that fatty deposit and that kind of irreversibility of that deposit. So that deposit comes from excess cholesterol in the blood. So some people are predisposed to hypercholesterolemia, high levels of cholesterol in the blood. Some people it's through poor lifestyle choices that they become hypercholesterolemic, and in some cases it's a bit of both. Something that's certainly over 40 we want to keep an eye on is our cholesterol levels, just to make sure we're not predisposing ourselves to kind of early heart disease. I think the one thing to point out is actually we're always going to get a certain amount of fatty kind of atheroma buildup through our life. It doesn't matter how kind of healthy we are, doesn't matter how kind of vegan and cyclist we can make ourselves. It's still going to build up to a certain extent, obviously depending on whether you're predisposed or whether you have those poor lifestyle choices, determines how quickly you get to this point. So what we say with heart disease is heart disease is the kind of build up over and above what would normally be expected in an adult of your age. So if you're more this end in your kind of 40s and 50s, then that would definitely be termed as heart disease. And what we then refer to as angina is when this heart disease gets to the point where actually it's occluding the artery. So these fatty buildup is occluding this artery, i.e. making the available space for blood to flow so narrow that actually the heart muscle further down the system is not getting enough blood to support what it's doing. And the first symptom of that is going to be chest pain. And we refer to that as angina. So when we're getting chest pain as a result of heart disease, as a result of fatty buildup in the arteries, we refer to that as angina. Now, there are two types that we're going to discuss. But does anyone just want to throw in the chat, does anyone know how much, in a percentage terms, how much this artery has to be occluded before you start to get, or typically would start to get angina symptoms? Very good. So anyone else want to have a go? Anyone throw in the chat? 45, 40, any advanced 40? A few people saying 40, 50, 55. 50. The only correct answer I've had so far was in a private message to me, actually, so nobody can see it, and it's somebody that's on our current FREC 4 course. I know we've talked about this, so yeah, there you go, Dominic. Put it in the public. Well done. So it's actually 70%. So, which I think is pretty incredible. It shows you how kind of resilient the body is and how much it expects to be abused in life. I don't think that's an excuse to go and eat as many kebabs as you possibly can, but it does just show you how much resilience there is built into the system. That actually this deposit needs to build up to about 70% actually before we start to get symptoms of angina. I think that's pretty incredible. So that's a typical person. Obviously, everybody's going to be slightly different. So now we're going to stop at this diagram here, which is just a kind of steady build up. Now, if you were to, if this patient here with let's say that's 70% occlusion, and this patient now has a diagnosis of angina because a couple of times they've presented with chest pain and they've done an angio or however they've decided to diagnose this one, and they've said this patient has angina. What would happen if this patient decides to exercise particularly hard? You know, they say, do you know what, enough's enough, so I'm going to jump on a treadmill and have a little jog. Now that heart is obviously going to be working very, very hard. Its oxygen demand is going to go up, and actually if that vessel, this is the left anterior descending vessel that's depicted here, but it could be any. But if let's just say that LAD is 70% occluded, and the bottom of the heart here is working really, really hard, because actually this anterior wall here is a part of the left ventricle. This left ventricle is working really hard now as this patient with angina is on the treadmill. And suddenly it's going to get to the point where actually this heart muscle here is asking for so much blood and oxygen that this vessel can't supply it anymore. The first symptom of the heart muscle not getting enough blood is some chest pain. Okay, so what we say then is stable angina, which is the first type of angina we're going to talk about, is nice and predictable, because actually we knew that was going to happen, didn't we? We knew that if this patient has an occluded artery to the point where if they do something really, really kind of strenuous, they're going to get some chest pain, then it follows that if you get that patient to sit down, stop running on the treadmill, that pain should go away. So stable angina is nice and predictable in that if you increase the oxygen demand of the heart, then of course we're going to see some ischemia, which is the posh word for saying that the heart muscle isn't getting enough blood. And that ischemia is going to feel chest pain, is going to give you the sensation of chest pain, possibly some breathlessness as well. So, and then the predictability comes from actually if you take away the trigger, if you reduce the oxygen demand of the heart, so reduce the stress or reduce the exercise burden, their pain will go away. That's helped by a drug called GTN. GTN is a drug that's often prescribed to patients with angina. It goes under the tongue, and what it does is it relaxes the muscle around these little arteries. And if it relaxes the muscle, it makes the lumen bigger and it allows more blood to flow through. So that's how GTN works. The big side effect of GTN is dropping blood pressure, as we'll talk about a little bit later. So Sam, TIA, transient ischemic attack, is a mini stroke effectively. We're going to talk about that next week, actually. So hold on to that thought. So good. So that's stable angina. So what is angina? So I'll tell you what. We'll go through what is angina, and then I'll flip back to that picture. So angina is, and it wants to work, it's insufficient blood flow through to the heart muscle. That's caused by that progressive narrowing that we've just talked about. And the posh word for that is ischemia. So there are two types. We have stable and we have unstable. Stable is very predictable, what I just said. If you increase the oxygen demand of the heart through stress, through exercise, etc., we get chest pain. We then remove that oxygen demand and the pain goes away. Unstable is unpredictable. So that chest pain coming on suddenly at rest, or when you're not doing any particular exertion or nothing out of the ordinary, and you suddenly get chest pain. And actually, with sitting down, resting, and taking your GTN, it doesn't go away. Then we're thinking much more unstable angina. And unstable angina is one of the acute coronary syndromes that we're going to talk about in just a little while. But that is when the artery occludes by this process here. So this is your patient with angina or heart disease. It may not have been diagnosed as angina yet. And actually what can happen with these fatty buildups is every now and again, for reasons sometimes unknown, they rupture slightly. And as they rupture slightly, they encourage blood to clot around them. Now that blood will clot nice and quickly because these the kind of material that's contained within these arteriosclerosis kind of buildups are kind of programmed to attract blood and attract clotting and things like that. So this clot forms very, very quickly. Now, if you've got a patient with heart disease and a kind of 50, 60, 70% occlusion of their coronary arteries already, it doesn't take much of a clot to bring that up to 80, 90, 100% occlusion, does it? So that's what's going on. The three processes that we're going to describe in acute coronary syndromes. The same thing is going on. Okay, this buildup of fat has ruptured, and that rupture has caused a massive clot to form over the top. And actually, that forming very, very quickly, it doesn't take long to completely occlude that. Now, it prizes for guessing kind of what happens to the heart muscle further down. If you completely occlude it, it might survive for a little while, but ultimately it's going to die eventually. We're going to talk about heart attacks, which is death of those muscle cells fairly soon. So angina, stable angina, this is what's going on. It's just you've kind of reached critical mass within your arteries. Acute coronary syndromes, this is what's going on the right-hand side of your picture here. We have one of those kind of plaques ruptures and a clot forms, and that clot acutely kind of closes up the vessel. Good. So that gives you possibly unstable angina, possibly one of the heart attacks. We'll talk about that shortly. So some recognition features of angina here. So we would expect response and airway to be normal. There might be some slight breathlessness with angina. The key here is central chest pain. All of the things we're going to talk about, all of the cardiac kind of illnesses that we're going to talk about for the first bit here are all characterized by central chest pain. Now, of course, those of you that have done some reading around this know that commonly you get radiation down the left arm, you get radiation into the jaw, you get nausea, vomiting, dizziness, lightheadedness, signs of cardiogenic shock, because ultimately they might be in some form of acute heart failure, which we're going to talk about at the end of the session. Heart rate can be normal in some heart attacks or angina. Actually, you can get bradycardia, slow heart rate. Blood pressure may be normal, it may be low. Cyanosis is possible if your blood pressure is dropping. Cyanosis is going blue because of not enough oxygen. Just commonly, they're very, very pale. sweating profusely. So, and an ECG might be normal. There might be some ST depression. We're not going to talk about that tonight. Those of you that know what ST depression is, you might see that in angina. In terms of your disability on your primary survey, their GCS might be reduced if their blood pressure is very low and their brain's not getting enough oxygen. Their blood sugar might be increased, so there's some correlation between raised blood sugars and acute kind of cardiac events. Pupils are unlikely to be different. Again, if you become profoundly hypoxic, your pupils become a bit sluggish and dilate slightly. In terms of E, we're not expecting a fever here. This isn't a kind of immune system disease. This is not an infection, shall I say. This is a blockage of an artery. So actually, we're expecting no temperature, and nausea and vomiting is very, very common, as are dizziness and other kind of secondary symptoms. So again, just the key with angina is to think onset and recovery. If it's predictable in its onset and they get a rapid and full recovery, then we're thinking stable angina as opposed to unstable angina, which is of course one of the acute coronary syndromes, which we will talk about shortly. So treatment for angina, similar to all of the heart kind of side effect or suspected heart effects really. So calm and reassure your patient, move the patient to a quiet environment if at all possible. Do get a good history. A lot of the diagnosis of chest pain is going to come from your history, and actually in the early stages you should be able to pick between unstable and stable angina, or something that you might think is stable angina and something you think is going to be a heart attack. There should be some kind of correlation there with your history. So following exertional stress suggests stable, and at random suggests unstable, or an ACS cause, which we'll talk about in a little while. Patients with chest pain, especially if you're thinking this could be heart, full set of observations, including a blood pressure and an ECG if you have the facility to do so. Even if you don't know how to read it at this stage, having that copy of the ECG early on in this disease process is really, really helpful later on down the line when things may have changed. So there's no legal reason why anyone can't give 300 milligrams of aspirin to chew to somebody that is having a suspected angina or heart attack episode, clearly unless it's contraindicated. But again, follow your local rules of where you work, but there's no reason why anybody can't give that. Entonox as required, PRO means as required for pain relief. Entonox is very good for pain relief for chest pain, particularly when it's of cardiac nature. I put, like last week, I've put the things in blue that require you generally to have some additional bolts on. Obviously, Entonox is covered on FREC 4 as standard. It's covered on our FREC 3 as standard, but not all FREC 3s out there can administer Entonox. So I've put that in blue, just so as long as you're qualified to do so, give the patient some Entonox. GTN, again, it's in blue because it's only if you're qualified to do so. You need to have done safe administration, life-saving meds to administer GTN from your own bag or from a kit bag. So 400 micrograms sublingual, which means under the tongue, provided their blood pressure is stable. So we want to repeat that every 5 to 10 minutes unless their blood pressure drops below 90 systolic. And that is one of the big side effects of GTN. It drops blood pressure. So it's more often you give it until their blood pressure drops, but that's fine. Again, I've just put in black there, anyone may assist the patient to take their own prescribed GTN. That's not to say just because the patient has it in their pocket doesn't mean you can't give them some. You can certainly assist them to take their own medication. The reason GTN is in blue, though, is if you want to give it from your ambulance kit bag, you need to be suitably trained. With all chest pains, particularly if you're thinking heart, monitor closely for deterioration. Look for any ECG changes. We call them dynamic ECGs, and it's very, very kind of characteristic of some, developing heart attacks. People going from unstable angina into the heart attacks quite often have some very kind of dynamic changes on the ECGs. Even if you can't spot them, you haven't done any training to spot that type of stuff yet. It doesn't matter if you've got the ability to take some ECGs off and keep them to one side, when the paramedics or when they get to hospital, that's going to be very, very useful to the clinicians that are looking after them. So consider monitoring with the defib pads. There's no harm in popping the defib pads on just in case the patient does go into cardiac arrest. There's always the question of, is that going to scare the patient into cardiac arrest? I've never known it to. I think people are just thankful that we're doing what we need to do to keep them alive. And actually, I think they'd rather, if anyone kind of really stopped and thought about it, actually, if I'm in the throes of a heart attack and I'm likely to go into something like VF, a shockable rhythm, then those precious few seconds of getting the pads out of the packet and putting them on my chest are actually reducing my chances of surviving. I'll take it, thanks, I'll have them. So yeah, I think that's routine for me. I think most clinicians in the ambulance service, once they identify a big stonking MI, we tend to we tend to put defib pads on to monitor the patient just in case they do go into VF. I've seen it happen enough times to know that it certainly can. So the key here with anything at FREC 3 and FREC 4 level is making sure you've got senior clinical support on the way to you. If that's not possible, or if that's going to be very kind of a slow process, then get going off to the nearest A&E department. Okay. When we talk about heart attacks later, I will put in the caveat of, if you're, depending on where you're working, there may be a particular pathway for suspected heart attacks at ACS, but in this case, to the nearest A&E is going to be a fairly good default for you. So good, perfect. So a bit of a case study then, to see if you've learned something from that then. I've got 69-year-old Winston, he's overweight. He's been walking up a steep hill in the park and he now has some central chest pain. When you arrive, he's sitting on a bench looking a bit pale, clammy, and he's in obvious discomfort. He doesn't look well, bless him. So your primary survey, it's safe to approach. He's responding normally. There's no concern to his airway. He's slightly breathless. Respiratory rate is 24, so that's a 95, and you don't have entitled carbon dioxide function available to you. His heart rate is 90, blood pressure 110/60, but his ECG does not show any ST elevation at this stage. GCS is 15, blood sugars are a bit raised, 8.2, and his pupils are normal. His temperature is 36.7. Okay, he's had no cardiac history. He hasn't been prescribed GTN. But since you've arrived, Winston's symptoms have started to settle. So as you're sitting there talking to him, calming him, reassuring him, and doing his ECG and so on and so forth, he starts to feel a little bit better. Okay, so let's go to, bearing that in mind, let's go to Menti. Menti.com, pop in the same code again, 27208876. What's the most likely diagnosis and what medication would you expect to give? Have a little think. There's a little caveat on that of if you were SARM trained, I should imagine, but we've talked about them. So what is the most likely diagnosis and what medication would you expect to give? So we've got stable angina, and we're going to give aspirin, GTN, and Entonox. Stable angina, aspirin, GTN, Entonox, clopidogrel. Unstable angina, aspirin, GTN, and Entonox. Or is it unstable angina? We're going to give aspirin, GTN, Entonox, and clopidogrel. I'll let a few of you get voting there. Let's see where most people are going. Most people are going for A there. So most people thinking this is, well, everybody so far is thinking this is stable angina. 8% of people thinking we're going to give clopidogrel. We haven't talked about clopidogrel yet. So stable angina for Winston in this case. Stable angina, his blood pressure is good. We're going to give aspirin, GTN, and Entonox. Aspirin to thin the blood, GTN to dilate the blood vessels, again, only if you're CPD trained, and Entonox, again, if you're CPD trained, as a very, very good pain relief and slight sedative for Winston. So very, very good to most of you there. That's fab. Let's go back. So the acute coronary syndromes then. So they are three conditions. I mentioned that already. They're characterized by the acute blockage of a coronary artery. So in that first picture that we saw that we've got a small version of here, this one, vessel number 3 here was your stable angina or heart disease going to stable angina. This fourth vessel on the right here is the acute blockage where there's a small blood clot forming there, isn't there? So those three conditions characterized by acute blockage of a coronary artery, they are unstable angina, so angina that comes on at rest, non-ST elevation, myocardial infarction, lots of words there. Non-ST elevation means there's no ST elevation. Myocardial infarction, death of myocardium, quite literally. Myocardium is the heart muscle. So non-ST elevation, death of heart muscle, and ST elevation, myocardial infarction are the two types of heart attacks. Okay, so angina is ischemia. We talked about that. Infarct is death. Okay, angina is ischemia, infarct is death. That means the only difference between unstable angina and the other two is that nothing has died yet. But we have got the difference between NSTEMI and STEMI. So is the presence of ST elevation on ECG. Again, I'm not going to cover that tonight. I'll cover that in the ECG session because it makes much more sense when we put it all together. But if there is ST elevation present on the ECG, then it can only be in the presence of chest pain and obviously symptoms that make you think heart attack. It can only be STEMI. Okay, ST elevation MI. If there is no ST elevation, it could be unstable angina, it could be NSTEMI, it could be a chest pain of non-cardiac cause, couldn't it? But the golden rule here is a normal ECG does not therefore rule out ACS, because you can have a normal ECG in NSTEMI. You can have a normal ECG in unstable angina. Okay. The only way to tell the difference between unstable angina and NSTEMI is with a blood test. And the key here really is one condition may lead to the next. All right. So repeating the ECG. Sometimes unstable angina, it's left long enough, can turn into a non-ST elevation MI. It can turn into a STEMI, ST elevation MI. Okay. The only way to tell the difference between angina and MI, the only difference being nothing's died yet, but now in NSTEMI, in NSTEMI and STEMI it has died, is through the troponin blood test. You may hear about troponin when people are going in for trops. That's because we're trying to tell the difference, but we're trying to tell whether they've had some form of non-ST elevation MI if their troponin is positive. Okay, good. Recognition features of acute coronary syndrome then, very, very similar. Central chest pain, again, we're going to ask about the onset. So unpredictable onset without recovery, we're thinking acute coronary syndrome. Now, the only difference between those that we're going to be able to pick out now is whether or not they have ST elevation. So we have unpredictable onset of chest pain without recovery and ST elevation. That's a STEMI until proven otherwise, ST elevation MI. If it's unpredictable onset without recovery and we have a normal ECG or some other changes, ST depression, I've put in there for those of you that know what that is, then we can't tell the difference. It could be unstable angina, it could be NSTEMI. The only way we're going to be able to tell the difference is to take it to hospital and get a blood test. Again, all of the other stuff is going to be very, very similar to angina. So I always say to students when you're learning this for the first time, when the patient is sitting in front of you with chest pain, you cannot tell the difference between stable angina, unstable angina, NSTEMI or STEMI, because actually the patient still has symptoms. Only when the patient recovers fully with a predictable pattern can you say, okay, that was probably stable angina. If they still have symptoms, it could be anything, couldn't it? Once you do the ECG, you'll know whether or not it's a STEMI. If it's not a STEMI, then that means it's still leaving the unstable angina versus NSTEMI debate, which is always a difficult one to manage. So the treatment for kind of when we're suspecting acute coronary syndromes is broadly the same: calm, reassure, to a quiet environment and getting a good history. So we want that random onset of chest pain for an ACS diagnosis. Full set of observations, including blood pressure and ECG, again, are going to be ideal. Aspirin 300 milligrams again to chew, okay. I should have said the reason we get people to chew their aspirin instead of swallowing it is because the liver metabolizes it in such a way that actually if you swallow the tablet, you don't get quite so much of the anticoagulant properties of aspirin. If you chew it, it gets soaked into the blood through the buccal membranes, which bypasses the liver, and therefore it makes the blood thinning action of aspirin a little bit more effective. Entonox, again, if you're qualified. GTN, again, if you're qualified, provided the blood pressure is stable, repeating every 5 to 10 minutes. Again, anyone can assist them to take their own. I've put clopidogrel there in red, okay? If you're suitably trained and your company allows you to do so, I've never known a company allow anyone other than paramedics to administer clopidogrel, because it's such a risky drug. Clopidogrel is a blood thinner like aspirin, and we're giving up to 8 times the recommended daily dose in the case of a STEMI. So I'm putting that in there in red just because I want you to be very, very careful. If you are SARM trained, you need to be at least SARM trained, and your company, your CQC registered organisation, needs to specifically allow you to give clopidogrel. As I said, very unlikely, but that's the other drug that now comes in with acute coronary syndrome. If this patient is definitely having a STEMI, we give either 300 or 600 milligrams orally, and that will be according to local guidelines, whether or not the patient is going to the Cath Lab or not. If you don't know what that means, then don't give it, okay? So, lovely. So Entonox, GTN, and aspirin, Entonox, and GTN are kind of the three that I'd expect people to kind of crack on with. Clopidogrel is a nasty drug, especially in high doses, so we want to be certain we're giving it for the right reasons. Again, monitoring closely, considering monitoring with the DFib pads, even more so if you're thinking ACS, or if you definitely have STEMI confirmed on the ECG. Again, senior clinical support either to come to you or meet you on the way and get going to the nearest A&E. As I'm saying here, if you've confirmed a STEMI by ECG and you're comfortable with that and your local pathways allow, then actually we bypass A&E and we go to the catheterization lab, so the cardiac Cath Lab, which is where they have dyno rod, isn't it? They clear the blockage and allow the flow to return. So if we can diagnose STEMI, we in the ambulance service often take them directly to the Cath Lab. But again, you'll follow the instructions of your company, I'm sure. But those of you working as ECAs will hopefully be aware of the PCI or the Cath Lab pathways that are available to ambulance services. So, and that only applies to STEMI generally. Good. So another case study then. So we have Frank, 55-year-old, has got a long history of high blood pressure, hypertension, that's what HTN means, and high cholesterol. While sitting in the pub, good on him. Now the pubs are open again. Frank experienced a sudden central chest pain and dyspnea, difficulty breathing. Okay. When you arrive, he's clutching at his chest, he's dripping in sweat, and he is very pale. It's safe to approach. He can only say the odd word, but he is alert, and that's because he's breathless. No concerns with his airway, but he has got some marked breathlessness. Respiratory rate 24, SATs are down 89%, and carbon dioxide is up slightly at 6.8. Remember, the normal range of carbon dioxide is 4.6 to 6 in a normal breathing casualty. Heart rate 52, blood pressure is down a bit, isn't it? 89/40, especially since he has a history of high blood pressure. ECG does not show ST elevation. It could show anything else in the world, but let's just assume it's a rhythm compatible with life that doesn't show ST elevation. His GCS is 15, his blood sugars are up slightly, and his pupils are normal, his temperature is normal. You're working with someone who's completed their SARM training. Frank's symptoms don't seem to be getting any better. And in fact, actually, you think looking at him, he is getting worse. So with all that in mind, let's go and have a little look at what we think could be going on here. So menti.com again, 27208876, A, B, C, or D. Which of the following medications would you expect to be given by your SARM crewmate or you if you have done your SARM training? Which are the medications? Aspirin, GTN, clopidogrel, and Entonox or oxygen or Entonox, because obviously Entonox contains 50% oxygen. So for the purposes of treating pain, it's okay to swap from oxygen onto Entonox. Aspirin, GTN, oxygen or Entonox again, just oxygen, aspirin, oxygen, just aspirin and oxygen or Entonox. So aspirin, GTN, clopidogrel, and one of the gases. Aspirin, GTN, and one of the gases. Just oxygen, or aspirin and one of the gases. Which one are we going to give Frank? I'll let a couple of you vote there. So we can get about halfway. Okay. Aspirin, GTN, clopidogrel, and one of the gases. Aspirin, GTN, and one of the gases. Nobody's just giving oxygen. That's good. And aha. I have managed to trick you. So, correct answer is D. 13% of you got it right. Well done. So, aspirin, GTN, clopidogrel, and one of the gases. Okay. So, clopidogrel is only given in ST elevation MI. Okay. And the ECG did not show any ST elevation. So, we know that the option with clopidogrel is wrong. You're right that just oxygen is wrong. He does need some other drugs. Aspirin. We've agreed aspirin is going to be given to anyone with cardiac sounding chest pain. GTN, one of the contraindications for GTN is blood pressure less than 90. His blood pressure was 89, I think, wasn't it? Systolic. So question D is the correct answer. Well done to those of you that picked that one up. So the only things we're going to give this chap are aspirin and either oxygen or Entonox, depending on your clinical judgment. He is in pain. If he's able to take the Entonox, then probably give him that. That will bring his oxygen saturations up naturally. If he becomes unresponsive, etc., then obviously just switch him to oxygen. So very well done to 13% that picked up on his low blood pressure and decided not to give him GTN. And just for those of you that picked the one with clopidogrel, you only ever give clopidogrel if somebody is having an ST elevation MI STEMI, and then only if you're allowed to, only if you know where the patient is going, i.e. to the Cath Lab. Good. Well done. So here we are. The last subject of this evening, heart failure. Okay, so what's heart failure? Heart failure is effectively an inability of the heart to beat efficiently due to structural damage. So it's not that the heart has stopped. It's not that the heart is not beating or kind of in some kind of discoordinated function, etc. This is structural damage leading to the inability of the heart to beat efficiently. So the two main causes are following a heart attack, an MI, and then uncorrected high blood pressure. Okay, so in the case of an MI, dead myocardium following an MI, doesn't contract and it becomes baggy. Do you remember from the first diagram I showed you that layer of heart muscle? When you kill it, when you take all its oxygen away and it dies, it becomes thin, it becomes baggy and stretchy, like a kind of a balloon that's been inflated and deflated too many times. But it doesn't beat, it's dead. So it's not going to beat when electricity passes through it. So it's just going to sit there all baggy and squishy. And actually, as the rest of the heart beats around it, it extends almost. So it absorbs all the pressure of the rest of the heart. It's a progressive illness. It's only ever going to get worse because as you increase the demand for oxygen from the heart, you kill more tissue. The other common reason, certainly in the Western world, is high blood pressure. So as the myocardium works harder, so it's beating against higher blood pressures within the system, the myocardium gets thicker. As it gets thicker, it becomes stiffer, and actually it beats less efficiently. So, and again, that's not a reversible illness. Once that's happened, that's happened. So really important to keep on top of your blood pressure because it doesn't take long for the myocardium to start thickening and getting stiff if you're running with high blood pressure for any length of time. So here we are, some pictures depicting it. So where it becomes baggy and thin is often referred to as systolic dysfunction, but ultimately it's as a result of dead tissue. This dead tissue, as you can see, compared to the normal heart, is thinner. It's thinner and it's baggier, it sags, and actually it doesn't beat. So it's only this part of the heart, perhaps, and this part of the heart, maybe some of the anterior wall that's beating. And actually, with each beat, maybe that's extending slightly and absorbing some of the force that the heart's beating out with. What happens ultimately is that that your systolics are reduced, or your cardiac output is reduced quite substantially. Moving over to the right here, what we all class as diastolic dysfunction, which is when you have a thickening of the heart muscle and stiffening of the heart muscle. If that heart muscle becomes thick and stiffened, it can't beat as much, and actually, again, the cardiac output is reduced. Okay, so that's normal versus the two different types. Okay, so let's click onto this. So so the thing to understand with heart failure is actually that's one of the problems. One of the main issue is the resulting side effects of the heart failure. So when that ventricle can't eject efficiently, and predominantly it's the left ventricle that gets affected the most because that's the most important of the two ventricles. It's got to eject the blood a lot further than the right ventricle, so only going to the lungs and back. Once the ventricle gets to the point where it can't eject efficiently, that pressure builds up in those vessels supplying that side of the heart. So if you remember from the beginning, the left side of the heart is supplied by the pulmonary vein. The pulmonary vein links the lungs to the left side of the heart. The right side of the heart is supplied by the vena cava, and that links to all the organs around the body. So when that pressure in those veins builds up, so pressure in the pulmonary vein and the vena cava start to build up as a result of heart failure, the fluid at kind of the ends of those vessels leaks out into the surrounding tissue. Now, at the end of the pulmonary vein is the lungs, and at the end of the vena cava is all the organs, all the parts of the body. Now, with the vena cava, gravity plays a part. So the lowest part of the system is your feet, isn't it? Generally, because we stand up quite a lot. So the right side, when the right side is knackered, you quite often get peripheral edema, so build up of edema around the ankles and things like that. So fluid in the lungs gives pulmonary edema. Fluid around the body is peripheral edema. Peripheral edema generally forms at the lowest part of the body. So in patients that are bedbound, that generally tends to be around the bottom in the sacrum. In patients that do stand up or do have their feet on the floor, it's likely going to be around their ankles. So that is why fluid builds up. It's because pressures in the system have built up and actually fluid just gets pushed out into the surrounding tissues. And hopefully that makes sense to you. So how are we going to spot kind of acute heart failure or heart failure with symptoms? Response is going to be normal. They may struggle to speak with the breathlessness that results particularly from pulmonary edema. You're going to hear fine crackles when you listen to a chest. So those of you that have done breath sounds, if you know what fine crackles are, if not, there's some good YouTube videos. You can listen out for. That's the sound you're going to hear through your stethoscope. Fine crackles, which is fluid on the lungs. Coughing, so fluid on the lungs will cause the patient to cough. Difficulty in breathing with a high respiratory rate and normal or low saturations, depending on how bad the disease is. Again, to counteract that, the heart rate increases, doesn't it? Blood pressure is unreliable because it can be normal, it can be high, it can be low, it can be indifferent. So actually reading the blood pressure in heart failure isn't going to tell you that much. Again, cyanosis in severe cases where the oxygen levels are decreasing because of cardiac failure. The ECG may be normal. They may not actually have an abnormal ECG as such in cases of heart failure. GCS again might reduce with the hypoxia. The blood sugar isn't likely to change that much, although you've got to query whether the patients like this may have some underlying diabetes as well. Pupils will be normal, temperature will be normal, and pitting edema around the ankles. That edema, fluid buildup around the ankles, is often referred to as pitting, because when you put your finger in it, you leave a little dent for a little while, and then it eventually refills. So if you push your finger around the edema around the ankles, and it leaves a little dent, not hard enough to hurt the patient, of course, and if you leave a little dent, that's called pitting edema. Good. So treatment for heart failure, again, is calm and reassure, sitting upright in a comfortable position. This is a breathing issue. The tripod position is often the best, and actually a natural the position that the patient will naturally fall into. And move to a quiet environment, again, to reduce stress, to reduce kind of pressure on the system. Full set of observations, including blood pressure and ECG, again, is going to be ideal. Oxygen as required, because saturations may drop off if the lungs are full of water. So oxygen is required to maintain sats of 94. Now GTN pops up again in heart failure. We're allowed to use GTN to treat acute pulmonary edema. So where there is water on the lungs and that is causing the patient acute breathlessness, we are allowed to give GTN in the same way as we would give it for angina. Okay, it's the one people forget about often. The only thing to bear in mind, blood pressure needs to be very stable. Actually, it needs to be over 110 for us to give GTN. The maximum dose in the case of heart failure is 2.4 milligrams. Okay, so that's 6 doses of 400 microgram GTN spray. Every spray is 400 micrograms. So we give one, 5 minutes later, another one, 5 minutes later, up to a maximum of 6, provided their blood pressure stays above 110 systolic. Okay, and does work, generally does work. Paramedics will give furosemide. You may hear that drug mentioned as well. Paramedics give IV furosemide to acute pulmonary edema, and that again does also work, but not quite as quick as GTN. Senior clinical support and transport to nearest A&E as usual. That's the standard kind of bottom line, isn't it? So here's your last case study then of the night before we wrap up. Peter, 66, he's had a large MI last year, although he is recovering well. He calls 111 because he's more breathless than usual today. He does come to greet you at the door. It's safe to enter. He's alert. He's patent airway, but he is coughing occasionally. He's got quite significant breathlessness. His respiratory rate's up at 28. So that's a 94%, but his end-tidal carbon dioxide isn't available at this stage. His heart rate's 90, blood pressure's 120 over 50, and his ECG appears normal. He's fully conscious, GCS 15, blood sugar's up a little bit, and his pupils are normal. He has a normal temperature, and he has bilateral pitting edema to his ankles. So when you examine his ankles, you can feel that water. Good. So his GP's recently changed his medication to help, but it's suddenly got worse today. When you listen to his chest, there are some fine crackles on both sides, and you as the clinician have completed your safe administration of life-saving meds. So you want to think about what medication might you want to give Peter. So let's heading over to, if you can see that. So let's go to the next question in our interactive session this evening. So what's the correct treatment plan? We're going to give oxygen for suspected heart failure. We're going to give aspirin, as Peter might be having another MI. Going to give GTN for acute pulmonary edema, or we're not going to administer anything. Have a little vote. What would you like to give in this case? Oxygen for heart failure, aspirin for another MI, GTN for pulmonary edema, or nothing at all. And bearing in mind you have your SARM training. So a few of you have a vote. Oxygen, aspirin, GTN, or nothing. Let's have a sneak peek at where some of you are going. A few of you giving aspirin for suspecting another heart attack, and most of you giving GTN for acute pulmonary edema. Good, so nobody just giving oxygen, nobody giving nothing. A few of you thinking aspirin, so there's no indication of chest pain there. There's nothing making me think that Peter might be having another heart attack, and his ECG appeared normal, so we're going to go with GTN for acute pulmonary edema. The answer to that was because the crackles on his chest, the fine crackles on his chest suggest fluid. Sudden worsening in breathlessness makes us think acute pulmonary edema. GTN is absolutely the correct drug to be giving, provided his blood pressure stays above 110, and it was only 120 to start with, so it may drop off a little bit as the process goes on. So next question. Oops, if I can get the thing to advance. What's the lowest blood pressure required to administer GTN for pulmonary edema? Was it 120, 110, 100 or 90? Have a vote. Good. A few of you coming in there. Lovely. A few of you getting caught out there. So it's 90 would be the answer for chest pain, for angina or heart attack. It is 110 in the case of heart failure. Okay. Heart failure for pulmonary edema, sorry. In the case of heart failure, the GTN will work a lot more effectively and will lower the blood pressure a lot more readily than it will in somebody that has a healthy heart that doesn't have heart failure. So good, it's a higher, lower threshold, if that makes sense. So 110 systolic to give GTN for somebody with pulmonary edema, and 90 if you're going to give it to somebody with chest pain, which you suspect to be angina or heart attack. So how long is the action for GTN? Good question, Melanie. So its half-life actually is only around 5 or 6 minutes, hence why the dose can be repeated every 5 to 10 minutes. So actually, if you do give GTN and the patient feels really unwell, they feel really lightheaded, dizzy, faint, etc., you can be relatively assured that that their symptoms should resolve fairly quickly. The GTN wears off fairly quickly, but it might just be a case of not giving them anymore. No problem. So one final question for this part was how much oxygen are you going to give Peter? So none, because it's stats 94, 100%, 20 to 40, sorry, 24 to 60% through Venturi or 6 litres through a neb. This is the patient suffering with heart failure and acute pulmonary edema. How much oxygen are we going to give him? None, 100%, Venturi, or a nasal. All vote now, A, B, C, or D. Go to menti.com, 27 20 88 76 if you're trying this for the first time. Good, a little peek. A little bit of a spread there, aren't we? Everybody giving a bit of thought. So most people getting it right. His stats are 94. This isn't a red box guidance. Heart failure isn't red box guidance, as neither is heart attack. So we don't need to give 100% oxygen regardless. And with stats being normal, Peter, there's no indication that Peter has COPD. Not that it would make any difference anyway, but as his stats are 94%. 77% of you, they're correct. Those of you that went for the other options, just have a think about that. Very well done, everyone. Thank you for coming along again this evening. That is the end of the session. So if you have enjoyed it, we would ask if you wouldn't mind just leaving us a review somewhere just to say what your thoughts were. It does help us bring people along into our kind of courses, and obviously that then in turn pays for us to do this. So we would like to keep these free for everyone to access for as long as possible. So, but thank you very much for coming along. We do plan on running another one next Monday the 31st. Charlotte's just put the links in for Google, Trustpilot and Facebook, which are, if you wouldn't mind leaving us a review, that'd be lovely. Now there's a link there as well. If you just look at what Charlotte's put in, the link to the medal account. So if you'd like a CPD certificate for this evening, there's a free CPD certificate available. Just click on that link, fill out the feedback form, and you will have a free certificate generated. So that's that link is there. If you just scroll back a little bit, you'll be able to find that. Don't worry if you don't find it, or if you don't want to do it right now, it will appear on our Facebook and on our website again within the next couple of days. So registration's open now for the next webinar, so next Monday, 31st of May, and that will be a session on neurological pathophysiology. We'll talk about strokes and TIAs, etc. That's episode 6 in this series, so that's next Monday, and you can register for that through our website and through our Facebook link. So are there any questions from this evening? We do just now have the Q&A session, so for those of you that want to leave, you're not going to miss anything new. You're very welcome to everyone that's leaving and saying thank you. You're welcome. Thanks for coming along, and we hope to see you again next week for neurological pathophysiology. So next Monday, 31st at 7 o'clock again. Registration link on our Facebook page and on our website if you want to register now. If not, you'll get the reminder email on the day, I should imagine. And any questions coming in? So fine. So Sam and so yes, yeah, next week's bank holiday, absolutely. I tend to ignore bank holidays. Brilliant. Sam, I will message you, absolutely, QRisk3. There's not so much training really with QRisk3, but I will, I'll go through that in just a minute. And no, you're more than welcome, everyone. Glad everyone's enjoying it. Any questions, put them in the chat. So Sam, yours is the only question that's come through so far. So with regards to QRisk3, there isn't so much training as such. If you go onto the QRisk3 website, it's fairly self-explanatory, the kind of bits and pieces that you need. Obviously, you need up-to-date blood tests for the patient. You're going to need their latest lipid profile. You'll also need kind of height, weight, and a couple of blood pressures from them as well. So it's not something that we can generally just go in and grab from them. It's something you'll need to go in, do some tests, and then maybe a few days later come back and review their QRisk. It is a very useful tool in predicting cardiovascular kind of incidents, as it were, or chances of having a heart attack or stroke. And we do use it. QRisk3 is used certainly when we're looking at starting people on statins. Which I would imagine as part of the community, well, it certainly is. So we know that in mental health patients, we underdiagnose a lot of things like hypercholesterolemia, or we undertreat, should I say, things like that, and diabetes and high blood pressure, etc. So doing QRisk scores on your patients is absolutely going to benefit them. So yes, but no, there isn't so much training as such on that. Okay, I'm going to pause the recording since everything is now through.